A 7-year-old boy is brought to the emergency department after being rescued from a house fire. He was trapped in a closed space for an unknown duration. Upon arrival, the child is conscious but lethargic, with singed eyebrows, soot in his mouth, and facial burns. He is coughing and producing carbonaceous sputum. There is no stridor, but he has mild respiratory distress, with increased work of breathing and a hoarse voice. His oxygen saturation is 94%. On room air? The child's parents report that the boy was inside a room that filled with smoke, and he may have inhaled significant amounts of smoke. There is no known history of asthma or other lung disease. Questions. 1. What are the key components of inhalation injury, and how do they relate to this patient's presentation?
Inhalation injury can be divided into three main components. Upper airway injury. This occurs from direct thermal burns. However, in this case, there is no stridor, suggesting that the child may not have a severe upper airway burn. Chemical pneumonitis. Inhalation of combustion products, e.g., carbon monoxide, cyanide, or toxic fumes, causes pneumonitis. The child's cough, carbonaceous sputum, and wheezing suggest chemical irritation and damage to the airways. Systemic poisoning. Exposure to carbon monoxide CO or cyanide is common in inhalation injuries. The child's elevated carboxyhemoglobin level 12% indicates significant CO exposure.
2. Does this patient require intubation at this point? Why or why not?
Intubation is not immediately required in this patient, as there is no evidence of upper airway obstruction, no stridor, and the patient is maintaining oxygen saturation on room air.
3. What diagnostic test could be used to confirm inhalation injury and assess the severity of airway damage?
A bronchoscopy is the best diagnostic test to confirm inhalation injury and assess the severity. It can visualize mucosal damage, edema, blistering, or airway obstruction caused by soot or debris. Bronchoscopy is indicated especially in patients with suspected inhalation injury who require intubation or show signs of airway compromise.
4. What is the appropriate treatment for carbon monoxide poisoning in this patient?
The primary treatment for carbon monoxide poisoning is the administration of 100% oxygen through a non-rebreather mask or nasal cannula, which helps displace CO from hemoglobin and improves oxygenation. Hyperbaric oxygen therapy could be considered if there were signs of severe CO poisoning, such as altered mental status, or a carboxyhemoglobin level greater than 25%, though it is not necessary for this patient at the moment.
5. What additional treatment should be considered if cyanide poisoning is suspected, especially if the patient has metabolic acidosis?
If cyanide poisoning is suspected, the patient should be treated with hydroxocobalamin, a cyanide antidote. This binds to cyanide and forms cyanocobalamin, which is excreted in the urine.
I don't understand a lot of what they're talking about. But one thing is clear, they know what they have to do.
6. Why is prophylactic antibiotic use not recommended in inhalation injury?
Prophylactic antibiotic use is not recommended because it can promote the development of antibiotic-resistant infections, inhalation injuries, increase the risk of pneumonia, but antibiotics should only be used when there is clinical or microbiological evidence of infection.
7. What ventilatory strategy would be used if this patient develops pediatric acute respiratory distress syndrome parts?
If the patient develops PARDS, a lung protective ventilation strategy would be used. Advanced modalities like high-frequency oscillatory ventilation HFOV or extracorporeal membrane oxygenation ECMO may be considered in refractory cases.
Eight. What is the most likely cause of the fever, and how should it be managed?
The most likely cause is pneumonia, a common complication of inhalation injury, especially with airway debris and impaired mucociliary clearance.
9. What are the long-term concerns related to carbon monoxide and cyanide exposure in this patient?
Long-term concerns after carbon monoxide and cyanide exposure include neurologic sequelae, such as cognitive deficits, memory issues, and motor dysfunction.